Marnie Woodard, Spokane Valley here.
Kevin Freeman, City of Millwood.
Bob Lutz, Health Officer.
Tony Smith, Administrator.
Chuck Hafner, appointed at large.
Michelle Fossum, Legal Counsel.
And Vince Novel, Recording Secretary.
Okay, thank you very much. Is there any citizen input this morning?
There is none.
None. Okay, thank you very much. I have nothing to report this morning, so we will continue to item number 5, agency report, please.
So we'll begin with the Health Officer report.
Well, good afternoon. A couple months ago, I talked about the community assessment process, and I sort of wanted to review that a little bit, and then in conjunction with that, talk about what's going on here within the agency with our strategic plan. So if you remember, we identified through the community health assessment, there were 15 priorities, of which 3 kind of rose to the top, they being family trauma and violence, looking at co-occurring disease, which constitutes drug usage and mental health issues, and then the availability of affordable housing. So with respect to the family violence, I wanted to point out some statistics that actually our data center have been pulling together for us. So you can see in our community, child abuse is a significant concern. You see that we're significantly higher than the state. And we're looking at, again, over the past decade, it's been estimated that there are at least 10,000 cases of reported child abuse, and we know that oftentimes those are underreported, so you have to assume that the numbers are even greater than that. If you look at family trauma and violence, again, very significant concerns. You're looking at over the past 4 years, or from 2012 through 2016, there were over 16,000 reported cases. That's about 3,300 plus per year. That constitutes about 25% of all criminal cases in front of the system. Of concern is that each one of these cases can have multiple charges. 46% of the charges were for assault. 26% were for no contact violations. You can see that 43% approximately are dismissed, some for valid reasons, maybe some not so valid. And of a great concern is that about a third of these individuals go on to demonstrate recidivism within 2 years of family violence or domestic violence. Co-occurring diagnosis, this essentially refers to individuals who have 2 different diagnoses, substance use disorder and mental illness, either minor or major. Again, looking at these statistics, and again, we're using Better Health Together, which represents the Medicaid population, about almost 9% of Medicaid enrollees across the Better Health Together region. And if you think about Spokane County as having the greater percentage of those Medicaid enrollees, about almost 9% have that co-occurring diagnosis. And when you look at the rates of hospitalization, again, with co-diagnosis, again, you'll note that it's tend to be primarily in the 18 to 64-year-olds. Again, we have higher rates than across the state. And then again, if you look at it from the standpoint of race and ethnicity, much higher rates in people of color and American Indian, American Alaskan Native. Affordable housing. The blue graph basically represents those individuals who are spending more than 30% of their income on rent. And you can see that disproportionately, individuals across our community that are of lower socioeconomic status are spending an awful lot of their income on housing. And we know that unfortunately the amount of affordable housing right now is very, very limited. Agency priorities, again, the same, if you will, as what we saw at the community. We're adopting family trauma and violence, mental health, and to some degree probably also looking at suicide, and then chronic disease, and specifically chronic cardiovascular disease. These statistics, again, just suggest that for adults, people who reported 14-plus days per month of poor mental health, we are doing somewhat worse than the state. And if you look at, again, by demographics, you can see that differs based upon age and based upon income. Suicide rates for adults, again, higher than the state average. Greater numbers in the 18 through 44 range. That may be, we've talked about the diseases of despair, and that may reflect some of those findings. And again, males more than females. Just of note, in 2016, there were 91 suicides, of which 44 were gun-related. In youth, certainly we've heard about depression rates in youth increasing. Our numbers are about the same across the state. And again, you can see by demographics, females tend to report depression higher than boys. Also, we see that it tends to be something increasing as kids go through high school. I think this graph was very alarming when it was presented at the community health assessment, where you see significantly increased rates of both suicidal ideation as well as attempts. So although, again, someone may argue, it may be argued that these numbers are a little bit skewed because of the way that the data are being captured, nonetheless, you can sort of see that there's a trend upward prior to the significant bump in 2016. With respect to cardiovascular disease, it's actually the second leading cause of death across the state. It's interesting, however, that nationwide it's the leading cause of death, but in Washington state it's actually the second leading cause. In Spokane County, there were almost 800 deaths due to heart disease, about 18% of the total number of deaths in 2016. Slides are a little bit out of order. What I wanted to point out, however, is that, again, in public health, we talk about the social determinants of health. And the American Heart Association, back in 2015, actually published a scientific document that talks about the relationship between social determinants, which is, and this is the definition by the World Health Organization, and the relationship with cardiovascular disease. So if you think about, again, the different issues that we focus on in public health, i.e. socioeconomic position, race, ethnicity, social support, culture, there are significant findings that suggest that it's not just a function of what we do in the clinic, but also the environments in which people find themselves living. Yeah, it's a great question. Obviously, the new recommendations or preventive services guidelines came out recently and talked about, the different ways of prevention, the different ways that people should be screened. I think that we know that people are not getting screened as often as they should, and especially when there are means by which we can be screening at home without necessarily getting colonoscopies. I mean, I think that does speak much to the preventive message that public health and clinical practice should be emphasizing.
Thank you. Good afternoon. I have just a few things that I want to share with you. The first is very much in relationship to what Dr. Lutz was just speaking about, and that is looking at healthcare transformation that is going on. It is an alignment between physical health and behavioral health, which is an aggregate of substance use and mental health. But one of the things that is really being emphasized in this transformation is equity and recognizing the disparities that exist from the data that we just saw in terms of age differentials and certainly in terms of race and ethnicity, things that public health is really beginning to focus on significantly. This is a planning year for the accountable community of health called Better Health Together in our community. And we are now beginning to receive funding that is providing support for the planning that will go on to integrate these services in the coming years, beginning January 1 of 19. The agency ourselves are receiving funding for bidirectional integration and opiate work. And so planning on how we better integrate those services with primary care and mental health are underway for us right now. I had an opportunity last week to attend the National Network of Public Health Institutes conference and an opportunity to talk about Public Health 3.0 as Spokane has demonstrated. Again, looking at the report that Dr. Lutz just gave, you'll recognize that our emphasis really does have to start looking at the underlying causes of ill health for so much of our population. The other things that were covered at the conference, including developing workforce, looking at succession planning across the nation in public health. We have an aging workforce. We also talked about policy engagement and addressing issues of equity. Again, the things that were reflected in Dr. Lutz's report. I want you to be aware of a training that is coming up on June 13th. This is a follow-up to work that was done April 24th when we did more of an informational presentation about the opportunity to look at how health impact assessments can help us establish decision-making within our communities. This is particularly important as we talk about policy. How do we evaluate the impacts that policies may have on health? And health impact assessments are one of those methodologies that will be taught in a training on June 13th from 9 to 4. Many in the community are invited, all in the community who wish to attend are invited to learn more about health impact assessments. If you have any interest or know of others who do, please have them contact our data center. Then I want you to also know that our statewide association, the Washington State Association of Local Public Health Officials, has its annual summer conference here in Spokane, June 12th and 13th. So many of our staff will be there, as will representatives from across the state. Finally, wanted you to know also that in regards to health insurance that will happen during the transition of health care reform in our community, AmeriGroup, Community Health Plan of Washington, and Molina are the three MCOs that have been selected. And until they submit their plans to the state and get approved, they're still identified as the selected. But those will be the three plans that will be offering Medicaid services in Spokane beginning next year.
Can you say it one more time about AmeriGroup?
AmeriGroup, Molina, and the Community Health Plan of Washington, CHPW, it's referred to often. So with that, any questions? Great, thank you very much.
Thank you very much. Karen, do you have anything to report on the education committee this time?
I even have notes.
That's fine, whatever you'd like to report.
So before I begin my very brief report, Councilmember Linda Thompson is going to take a moment for a mindful moment. Okay. So this mindful moment has been brought to you by the Spokane Regional Health District Education Committee. We had our first meeting on May 17th to discuss the issues we want to address and a path to go forward. What we want to do is work in this committee to create a synergy between the policy committee and the education committee in the areas of community mental health, which we just talked about, and available resources to inform and raise awareness of the issue community-wide. We want that information to include mental health wellness programs and what other cities are doing in terms of mental wellness. We also want to look at the cause and impacts of suicide and provide information, and look at community resources and stress reduction practices, which some of us are in desperate need of. We are also interested in kind of the second tier is the cause and impacts of domestic violence and child abuse. These are topics, as you know, that are priorities of the Health District and were also the top priorities in the community assessment that was done just a little bit ago. And our goal as the Education Committee is to provide useful and easy to understand information and resources that we can all share with our constituents, our cities, the county. We want to support the work of the Policy Committee. We talked about creating user-friendly white papers, tips, Q&As, and information that can be easily put or transferred onto websites, and again, shared countywide. And we're also going to talk about other methods that we can inform and educate people on those two issues of mental wellness and child abuse and neglect. I'm going to turn it over to Linda.
So, you're going to be glad that we're on the committee. And it worked out perfect since I was stuck in traffic and talking to a mom whose child is having a lot of trouble in school because he's using opioids. And so I had to kind of rush. I didn't speed, and so I need to get you so what we wanted to do is to model wellness as a Board of Health and staff and whoever you would like to share this with. We can model taking a mindful moment during our days, during our projects, at stressful times, and you've each gotten a little treasure out of the basket, which a lot of times it's rocks, a lot of times it's a little treasure someone's found, but it's a reminder when you feel this, this glass stone to just take a moment. And if you would like to join, again, it's your option. We'd like to stand and do a little bit of breathing to help us relax. And we're hoping that this will be something you could use in your own meetings. I'm not sure the commissioners will jump up and say, let's all take a breath, but I know Arn would be totally supportive of this at City Council in Spokane Valley. To just take a moment and refresh ourselves. Often we don't take care of ourselves, and we're trying to do great work on behalf of our community about health, about making things safe, and making our communities a place where we all want to grow and live and have fun. And often we're not taking care of ourselves as the leaders who feel responsible for putting in policy and working on things. So if you would like to stand, we'll just take a moment and breathe. And you can hold your rock as a reminder. But it's important to ground yourself into the earth, to feel like you're strong into the earth. And then what we're going to do is just take 3 breaths and fill your belly. And so breathe in through your nose and exhale out of your mouth. And we'll do 3 of those breaths and just concentrate on treasuring who you are and thanking your body for the strength it gives you to do the work you do. So. So thank you. You can use this in the grocery store line. You can use it at your office. You can use it anywhere that you want to take.
We get to keep these?
Yes, these are yours. And if you didn't like the color you got, I have more in my bag. So, yes, just keep it. And
For those of you that have fallen asleep during that, time now to wake up, please. Okay. We get a report yet?
We had not had a meeting
Okay.
last week, but I'm glad that we have the support of
The education.
to work with it. We're interested in opioid issues, suicide prevention.
Okay, thank you. Mindful of the fact that Mary's not here, do you have a report relative to the budget committee or anything you'd like to add?
No, we have not got together since last month. We didn't get
Okay, all right, thank you very much. Okay, let's go to item number 6, consent agenda. Do I hear a motion for accepting the meeting minutes of April 26, 2018?
I move to accept the minutes.
Do I need a second?
Second.
Discussion? All those in favor, signify by aye.
Aye.
Those against? Thank you very much. Yes, we have the vouchers, April 1st through 30th of April 2018. Do I hear a motion to accept that, please?
Move to approve.
Second. I'll second.
Any discussion? All those in favor, signify by aye.
Aye.
Those against? It passes. There are no action items at this time, I don't believe, is there, Ann? Okay, thank you. Let's have a report, Disease Prevention Response Division overview, and HIV. Okay, thank you.
Well, good afternoon. It seems that I just gave a division report, but it's been a year ago. So I will be talking about very high level, the 6 units that I oversee in disease prevention and response. And then I was asked to frame it around the foundational public health services, which Bob gave a report a couple of months ago on. And then I'll bring up the 2 managers that will talk about the HIV programs. And it's been about a year and a half since we received that state contract that expanded our services. So you may have some questions around that. So here is the chart that was shown. And 2 of my programs fall into the area of foundational capabilities. And they're the assessment and the emergency preparedness and response. Capabilities are programs that go across the agency. They're very cross-cutting. They really relate to all of the different programs. And then these programs also work extensively out in the community. So data center and public health preparedness as capabilities. There is a flyer in your packet. It's titled Data Center. And it shows all the different services that the data center provides. On the right-hand side, it shows some of the latest publications that this group has done, including Confronting Violence, which had some of the data that Bob showed, and also the Injury Data and Prevention Report. These guys are always working on new assessments and doing a lot of evaluation work. The data center budget is primarily general funds, so even though it is a general program, there's no funding for it, and it's RCW. We're required by law to do data work and provide a comprehensive look in the community of what the data issues are. The other 40% is mostly grants, and then we have a fee-for-service model for those agencies that can afford to pay us for those services. Just some examples of quality improvement in the data center. They have this goal that they respond to data requests in less than 3 days, and they're always working to improve that timeliness of a response. But their data is showing very good. It's about 92% that they're able to meet that request. The other thing that they're working on this year is updating Spokane Counts, and they're developing a new website that will be more in line with what our customer wants. So they're using a whole quality planning process to do that. Then last month you heard from Tiffany Turner in the Public Health Emergency Preparedness and Response Program. So I won't go over a lot there, but this program has gone from just being a local and a regional program, Region 9 with 10 counties, to really focusing on half of the state and helping half of the state counties do preparedness work through healthcare coalitions. It's fully funded by the federal government. It's through the Health and Human Services Department branch, and it's a $1.6 million budget. This program is built on a Plan, Do, Study, Act program, and they do after-action reviews of every exercise or incident that we have, and then follow it up with an improvement plan. And they have set a goal of responding to at least 80% of those improvement items and making sure that they get to them by the end of the year. Another thing that they're working on in the area of quality improvement is making sure that our staff respond to secures alerts. And if you remember talking to Tiffany or hearing from her, she has also added the Board of Health as a listserv that we can add to secures and send out alerts from. So make sure that you respond to a secures alert because you'll feed into our data. So here's some staff. The data center has about 7.5 FTE. 4 of those staff are funded with general funds. The FEPR staff has about 10 FTEs, and they are hiring 2 more to do that Eastern Washington work. So the rest of my programs fall into the area of communicable disease control, including immunizations. So these are foundational programs that are mandated by law that public health provides. So these are the 4. And just going quickly through them and looking at services, funding, quality improvement projects. The CD-EPI one, they put out an annual 5-year report. I know with the new board members, I met with most of you, and I did show you the latest report. This one is hot off the press. It goes through 2016. We were hoping to have one for you today, and it will be out shortly. The staff respond to over about 2,000 communicable diseases every year. And this report really captures those trends, the new outbreaks, things that are going on an annual basis. This is an unfunded mandate, so about $460,000 of the dollars are general fund that goes into that program. We did receive some foundational public health services money, so we were able to add 1 additional staff. And then we have a CDC grant that ends this year, but it funds an individual to do infection prevention in all of the hospitals and long-term care settings. So their quality improvement projects, just a couple examples. They have a project that is to reduce the duration of gastrointestinal outbreaks in long-term care settings, such as the norovirus, which can be a very deadly disease because of the population it impacts. And the other project that they're working on right now is to see the percent of case contacts that we can verify where they were treated. So it's following up and really closing the circle of when we have somebody that has infected or exposed others to make sure those exposures were able to get treated. And we seem to hover right around 80%, and we'd like to see that up to about 95%. So some QI going on around that. The immunization program just put on a very successful conference last week called Vax Expo, and they were able to bring in some national speakers to that conference, and it was well attended with over 200 different people. This program has many components, and it's a program that I would love to come back and talk to more in depth. They do a lot of work in the community, working with the schools, the healthcare providers. They hold clinics. They improve the immunization registry and the use of that by healthcare providers. It's mostly funded through federal government, but we do have a Group Health Foundation grant that we've had for an ongoing time period, and they kind of just keep giving more money to us because they like what we're doing with those funds. We also have some state categorical funding and then some general funds that goes into that program. These staff work a lot with healthcare providers to try to get the provider sites, clinics, vaccine rates up. So they do a lot of recall work so that people are actually, the patients are called back into the clinic and finish their vaccine series. And then we reward these clinics of those that have met their goals. So it's a really a good effort. The STD side of the prevention program is mostly funded by state categorical funds with some federal funding. And then the HIV prevention side is mostly funded state and federal, but we put about $125,000 of general funds into it due to the needle exchange program. And not a lot of the state or federal money goes into needle exchange. Quality improvement projects there, a lot of times center on percentage of cases interviewed and completed. And the difficulty with that is that the number of cases and the complexity of cases all align with how many staff you have to work on those cases. So the percentage sometimes nosedives if we have a vacancy or something going on with the STD cases. We're also doing a lot of targeted testing where we're really looking at really high-risk areas of individuals, and right now we're doing some additional testing in our needle exchange program, STDs, HIV, and hepatitis C. Our medical case management program is fully funded by the state. It's a $1.4 million budget. And this program gets audited regularly by the state, and they really look at our charts and our client documentation. So they look for accuracy, completeness, currency, and so a lot of the QI projects are based around how those charts are doing. You're going to hear a little bit more from the managers on these programs, so I'll leave it at that. Staff-wise, there's 5.5 FTEs in the CD-EPI program and 5 in the immunization outreach program. There's 4 STD prevention disease investigators and 4 HIV prevention staff, and then there is 10 in the medical case management program. I'm very proud of these staff. They're very passionate about helping people, and they have been recognized locally, in the state, and nationally for their expertise. And it was very much recognized by the state when we applied for some foundational public health services money that I'll talk about next. So this is just a little bit of a glimpse of what happened in the 2017 legislature. The public health community really asked for $60 million to help start funding those foundational programs in the state. And we received $12 million of the $60 million as a one-time funding. The state kept $2 million of that and then passed on $10 million to locals, so $5 million each year in the biennium. They also carved out $500,000 for some demonstration projects. So for us, that meant the health district received $277,000 for communicable disease. It was very categorical. It had to go to communicable diseases. And then we also received a shared service project, and I'll talk a little bit about that, but that also had to go to communicable disease. So if you remember, about a year ago, I came to the board and talked about the local needs in our community, and that we have very high syphilis rates and not enough staff to handle all of the 2,600 STD reports that we get pretty much on an annual basis. We also have very low rates in the preschool population of immunizations, and so my request was to put on some additional staff. Due to the Foundational Public Health Services funds that came down to us last year, we were able to hire an additional STD disease investigator and an immunization outreach staff person. So that was very good. The shared service project, it really is a regional project, and we're using our existing expertise in our programs and helping the outlying counties that just can't hire or they just don't have the capacity to work in the areas of community health assessment and CD-EPI, communicable diseases. So Adams, Asotin, Lincoln, Northeast Tri, and Whitman counties are receiving staff support to help them doing their own community health assessment processes, like the one that Bob just talked to, and prioritizing their own local issues, and then helping them follow up on those. And then we are also doing a lot of training with our EPI staff, of brand new staff that they've either just hired or existing staff that they've had that may be wearing 4 or 5 different hats and just don't have the time to be trained up on every communicable disease that comes down. Both of these projects have been highly scrutinized in the state because they really are a pilot project to see if the shared service models work. And so we have a lot of data gathering and a lot of evaluation going on to see just the results of what they're doing. So that was really quickly a high-level overview of my division, and then I'll have the 2 managers come up and talk more about the HIV services. So Stacy Lachaux and Lisa St. John.
Any questions of Lydia before she sits down? Karen?
I just have a quick one. This I may be totally off the mark. But is there any data or work being done with that HPV virus in the community?
There's lots of different projects going on right now. Yes. We actually have a Group Health Foundation one that's working in that area, and then I know the CDC is doing one, and I think Kayla just popped in. There's another one going on. So we're trying to kind of coordinate with them and not step on each other, but yeah.
Okay, thank you, Lydia.
Okay.
Lydia.
Hi, I'm Lisa St. John. I'm the HIV STD Prevention Program Manager, and I'm going to do the initial part of this presentation for you, and then we'll bring on Stacy Lachaud, who has fabulously taken on and expanded the HIV Case Management Program Services component. So what I'd like to do really at the very beginning is I'm going to try to give you a quick overview of our statewide and local strategies to address the needs of people living with HIV and also very much our HIV prevention services. In 2014, End AIDS Washington was instituted. I think it was formalized in 2015. And it was essentially a group of organizations across the state that came together under the guidance and support of Governor Inslee to work together to reduce new HIV infections by 50% by 2020. The group put together a series of very complex processes and strategies and activities. And one of the primary ones is what I'm about to introduce to you is called the Cascade of Care. And what the Cascade of Care does is it points out what the overall statewide strategy is. And then as I go through the cascade, I'll try to describe to you how our programs here at the Health District, what they do to try to fit in to this cascade and where we try to intercede to improve numbers. I don't know if a lot of folks know or not, but Torney was the old HIV STD program manager. Just a little piece of extra information. So we'll also go through some, he was a fabulous manager, some county and state rates, provide a brief overview of the Washington State Department of Health contract as well. So this is the Cascade of Care. Do I look panicked? I'm looking for my text. Okay. So overall, I'm just going to do this sort of visually, but basically we're looking at our entire population who's at risk in Spokane. Right now we know the folks who might have the highest risk for new HIV infection are people who share injection equipment, and unfortunately still men who have sex with men are still very disproportionately impacted by this disease. So our population works. So the next step on that is HIV diagnosis. So this is the number of people living in Spokane who are living with HIV. Then we have our number of folks living with HIV who are engaged in care, which what that means is case management and working with the medical provider to get access to medications. And finally, that access to medications results in a suppressed viral load. This suppressed viral load is critical. Oh, there's a pointer. Okay, this suppressed viral load is critical to the Cascade of Care because for two reasons. Reason number one is that it contributes to basically the health and longevity and quality of life of a person living with HIV. A suppressed viral load means that HIV then for that person becomes more of a chronic condition, and they suffer folks suffer often don't get sick and can expect a normal lifespan. This is very, very different than what you may have experienced in the last 20 years even. So our program goals are to help folks get to that suppressed viral load. There's another bonus to that and something else that's really important, and this is also a public health perspective. That suppressed viral load, there are numerous studies out right now. With a suppressed viral load, somebody's HIV becomes undetectable. Although the HIV virus is still there, it's below detectable levels by the lab testing. What that means essentially is that if that's the case for that person, they cannot transmit HIV to another person. In fact, right now, I think some of the latest numbers I pulled is well over 96% effective in preventing HIV from being transmitted. This is huge. This is really just amazing. So we also use HIV medications, and I'll go through this. You'll have some more text, I promise. I think I promise. We also use the same HIV medications right here to help with prevention of new HIV infections. The very same medication, if taken regularly by somebody who has a high risk for getting HIV, can prevent infection. It's called PrEP, pre-exposure prophylaxis. And this medication, if taken every day again, can reduce the likelihood of acquiring HIV by up to 99%. The studies range from 92 to 99. It just kind of depends on which study you look at, but at either rate, anybody with medical training or any research experience can easily attest that these are extremely high. This is a really extremely high result. Very high outcome, very desired outcome. Okay. Any questions on the strategy before I move on? Okay. My text. Okay. So this is the part, now that you know what the Cascade of Care strategy is, what I'm going to do is practice with the pointer and try to illustrate to you how our various programs in the HIV care and prevention programs work together to address these various phases in the cascade of care. So our first one is, that population at risk, which we talked about, where in general, we're still seeing, which is still largely men who have sex with men and people who use injection equipment. So for that, what we have in our program is our needle exchange, which serves well over 1,500 individuals a year. And we also have our PrEP program, which again is pre-exposure prophylaxis. And that's the HIV medication that if we can get, in particular, somebody at high risk, into insurance and routinely taking this medication, even if they're still having some risk in their life, it could reduce the chances of them becoming HIV positive. So that's largely up on our prevention program. And then moving also in prevention is our targeted HIV testing. Lindy talked a couple of minutes ago about our needle exchange testing. We also do some very, very focused HIV testing in our program. What's critical about that is that one thing we do know is that that most folks are most infectious to other people in the first 2 months that they acquire the HIV virus. This makes it critical for us to identify and try to let those folks, make sure those folks know that they have this virus and try to get them engaged in care as fast as possible. So then we get to our HIV diagnosis, and then at that point, we work really close, our partner services program and our locating out of care services, and definitely our medical case management program that Stacy will talk about, do a tremendous job getting folks into insurance and helping them link into care, which you would think would be really easy. But when we're dealing with real people and real life people, we all need a lot of support. And as you know, people with lack of access sometimes need even more. So that's what we really want to do, is get those folks in to see the doctor. Next step is we want to help them continue to go see their doctor and take their medication every day so that they don't get sick, and that the potential for someone with compromised skills or basically the potential for a person who is taking their medication to transmit HIV to another person is extremely low. And I love that this animation is working. Okay, next step. You might be wondering, what's going on in Spokane? So in Spokane, and this is thank you to Boyd in the data center. In Spokane, in 2017, we had 596 people living with HIV in Spokane. Of them, 522, or 88%, were linked to medical care, and 75% were retained in medical care. That's really good. And because you might be wondering, what was it like before? And so, and this is a slide that I absolutely love, because this is 2013 compared to 2017. And the most important thing about this slide is in 2013, you saw that 81% of our folks were engaged in care. In 2017, 88. But I would like to note we had 113 more folks brought on board within that time span. Another really notable piece here is that 65% in 2013 had a suppressed viral load, and 75% in 2017. This shows obviously an upward trajectory and intimates certainly that our program efforts and Washington and Spokane strategies are effective. Speaking of Washington State, I'm just going to glance at this slide and then I'll show you Washington State's numbers. I was feeling really good about this fabulous upward spiral, and then I got the data about how we compare to Washington State. And we're actually doing exactly as well, no better or no worse than any other, than Washington State in general. So we're achieving a level of engagement and care and viral suppression that the state is doing in general. Okay, what questions do you have about that so far? Yes?
I do have a question about how many deaths we have each year from HIV/AIDS.
I do have that information, but I don't have it with me on a slide today. I can certainly send that out. I don't know if you have notes, but I can send that data maybe over to Anne, and she can send that.
So I actually have the FIDA report, and that is in here.
Okay.
So I'll pass that on again.
Because it seems like there must be good news that has gone way down as well.
Yes, and definitely since some of these wonderful new medications started coming out in the late 90s. So absolutely, you're correct that those numbers are decreasing across the state and in Spokane. So this is those living with HIV, and basically this is just Spokane County versus Washington State. We have kind of about largely the same amount for Spokane for the last 5 years. Washington State's a little bit higher. New diagnoses rates, we continue to be a little under Washington State. But in general, those lines, what my dream would be, the ultimate goal is I want to see that start to go down. And the hopes are when our numbers go up in the cascade of care, that fewer people will be diagnosed with HIV. How I'm doing on time? Okay, so I want to do a very brief transition into the contract from Department of Health in 2017. In 2017, Washington State Department of Health put forward a competitive RFP, which meant that anybody who had a contract had to write and compete for their contract. Historically, Spokane Health District had shared this contract with another agency. We were in a situation where we had to compete against each other to continue to provide our services. In this case, the contract was awarded to the Spokane Health District. And just to sort of give you a visual, we were also awarded to provide services to all of these Eastern Washington regions. So we're the gray section. And I know that looks like a lot of folks, and it is a lot of folks, but the vast majority of those are in Spokane when we look at numbers. Okay, so what I'm going to do next is provide you with a brief overview of how that contract changed our prevention services, and then I'm going to hand the podium over to Stacy Lachaud. So a small portion of this contract went to prevention, and what it did was allow us to expand our PrEP navigation services. PrEP navigation is an individual who's put in place to work with folks who need the extra help to get to their insurance, to find a doctor to prescribe PrEP, to help support them in taking the medicine every day. And then if they're falling away from PrEP and they still have a lot of high risk, to help loop them back in. We, of course, continue partner notification services, which is critical to get folks who are HIV positive into care, and case management. And we expanded our HIV testing back out for highest risk communities. And for the latter part of 2017, we're focusing on some community-based work, which I'm hoping will be led by almost peer-based, like people who are part of the community who want to lead some initiatives, which is a really vague way of saying, for example, we are working with the Men Who Have Sex with Men community. We want somebody in that community to advise our programming. So that's our next step with contracting. And finally, I would like to introduce to you Stacy Lachaud, who did a fabulous job taking the case management program, doubling it last year and achieving some of these wonderful numbers.
Thank you, Lisa.
Good afternoon. Thanks for having us today. So my name's Stacy Lachaud. I was brought on as the case manager, a program case manager for case management in early 2017. So right as the transition was happening, I came right on. We hired 4 additional case managers with this transition. 3 of the 4 of the case managers came from the Spokane AIDS Network. They had been working there, so clients saw a familiar face when they came on, so that was really nice. We now have a total of 7 case managers. We successfully transferred 140 clients during that early 2017 transition. We are now serving 420 clients currently. That's about a 50% jump from our 2016 team that we had. We were able to form a community advisory board. It's called the HAB. That meets here once a month, and they are tasked with looking at our services that we give to our clients and getting a voice to the clients and telling us if there's any improvement projects that they'd like us to change and do. Mental health is a big barrier with HIV care, and so we contracted with a mental health professional in the area, and she fills the gaps with clients that maybe need mental health and their insurances. They aren't able to get it through their insurances, so she is able to contract with us and give the mental health needs to those clients. Housing is a big barrier for our case management team. We have a large number of homeless or unstably housed clients. So we hired a housing specialist. That housing specialist just works on housings with the clientele. She works with landlords. She drives around and takes clients to go find places. She'll work on voucher systems, evictions, that kind of stuff. We were able to expand our housing financial part of our housing that we can give to clients. So we help with emergency, transitional, and temporary housing. And that is to fill the gap while they're waiting for a voucher system to get some affordable, stable, safe housing. Keeping clients in care is a big piece of this. So we hired a locating out of care professional. That person works with our case management team in finding clients that don't want to be found and helping us link them back into case management and stay with them until they get stable enough to be moved over with us. A big thing that was happening during the transition is the SAN food pantry closing. Clients were very concerned about that. We offer food vouchers to 2 area grocery stores. We also offer vouchers for non-food essential items as well that they can use as they need it for emergency help with food. We also have donations for dog and cat food to help with their little furry animals. And then this summer we're hoping to, and we actually have the plans to hire a client navigator. That is a peer of the clients that we will be working with our team to help engage clients in their health care. And we're going to hire another case manager, and that's just to keep our numbers in case management in a manageable area for our team so we can do everything we need to do for our clientele. We were also lucky enough to give our reception area a little facelift. So this is what it looks like. We've got a wonderful fish tank in the back there, some soothing bubbling noises, and the plants and the seating area there is all new. DOH helped us do that, and they came in and checked it out and said they really like it. And our clients daily come in to just say, this is so relaxing. Thank you for offering this to us. Transportation is a big barrier for case management, and we were awarded from Avista an electric car, a Nissan Leaf, that we are able to transport clients in starting tomorrow, hopefully. And this will help us. We have a lot of clients like finding housing and that sort of thing, to be able to not have to take the bus or Lyft. We're using Lyft a lot right now, and so this will actually increase all our services that we're giving our clients to make sure they're getting to their medical appointments, helping us find the locating at a care person can grab a client and stick them in the car and off they go. And just to give you some numbers on where our clients are at the end of 2017 in the cascade of care, these are some of our numbers here. And on the very bottom, if you note, 86% of our clients achieved or maintained viral suppression. That's 11% higher than Spokane County's averages. So I'm really proud of that number, and we're hoping to hit 90. That's our goal. But that just means that our overall health outcomes for our clients are on the right track. So, do you have any questions?
Any questions, Stacy?
All right, thank
Okay,
you.
thank you very much,
Thank
Stacy.
you.
Here's the 5-year report, so we'll take a copy.
Good job. We are now officially out of exec session at approximately 1:44 and 55 seconds. So we now will continue with board member check-in, please. Andrea? Okay. Doctor?
Down county physician.
Okay. Mr. Woodard?
Nothing to report.
Mr. Freeman?
Nothing at this time.
Ms. Stratton? Oh, do you have a little joke for us? Or
Want to do it now?
well, certainly.
Okay, we're testing out a new joke.
Did you think I was going to forget you?
What do a telephone and a dog have in common? Both have caller ID.
Nice. That's good.
That's a good.
Use from a rock.
That's a good one. Do you have anything else you'd like to?
Just this weekend, Saturday, is West Central Neighbor Days in Cannon Park. Still
Cannon.
Cannon Park, and it will be, I believe, the debut of the cops' horses that will be walking throughout the park, meeting the neighbors and playing with kids and making themselves visible. So it's the start of summer, and those horses will be hitting a lot of the area parks. And so look for them in your local park.
Okay. Pre?
Yes, just to connect with our mindfulness, one of my daughters recently presented a study that she did of female lawyers who, for 2 weeks, did a daily 10-minute mindfulness application on their phone, and compared to the control group who didn't, their anxiety levels went down statistically significantly. So, that's very good.
I was just going to say that in June is the Association of Washington Cities meeting, and I won't be here, and Arn won't be here, so we just wanted to point that out, but we'll bring good things back.
And mine is to thank staff for a good report today, and thanks board for doing what things you do outside of the South District in the different communities. So thank you very much for all that. And with that, I'll take a motion to adjourn.
So moved.
Okay.
Second.
All those in favor?
Aye.
Thank you very much.